we circulated an online Google form to assess the practice patterns of induction therapy in India. So this survey was an online survey and through Google form. The time period was from February 26 to March 17, 2024, and it was sent to ISOT members through official email ID, and across 400 transplant centers, we got the response of 254 centers. And the results were analyzed on the Google Forms and the Microsoft Excel. So these were the induction therapies which were considered for the survey: rabbit ATG, IL-2 blocker, graphalon, no induction, and alemtuzumab versus others. So the brief introduction about it: the total number of kidney transplants on the left side we can see in from 2013 to 2023, the transplant centers which performed how much transplants. So that shows the ratio. And we assessed also the number of transplants performed by the particular centers in 2023. So what we saw, the most common induction therapy which was used was rabbit ATG in almost 70% centers. Around 15% centers used IL-2 blocker, 10% used graphalon, around 5% prefers to use no induction as per the immunological risk, and the second most commonly used induction therapy was IL-2 blocker. Third, most of the people filled up as they did not use the induction when after assessing the immunological risk, and the least induction was the alemtuzumab. Now the first question for our panelist is for the Dr. Pratik Das. Sir, we can see in the survey the response rate of the factors influencing the induction therapy, the choice of induction therapy. So what is your practice, sir, and what factors do you consider when deciding the choice of induction therapy?
So thank you for including me in the panel. Whenever we talk about the term induction, the primary aim is to prevent the rejection in the immediate post-transplant period, so that the graft survival and the patient survival in the long term that is improved. So when we choose an induction treatment for kidney transplantations, we need to see this primary thing first, and at the same time we need to assess so many things: the patient safety, affordability, practice, and so on. So what you have shown in your, this is important that when we are beginning in a center, then it is always better to follow the guideline, because the scientific evidences are always behind this guideline. So presently KDIGO has given, as sir I was telling, this is a pretty old, this is a 2009 guideline. We are expecting a new guideline that is important. But while choosing the second, and most of us and including ourselves are practicing the assessment of the immunological risk. Especially the patient has an HLA mismatch, he has an panel reactive antibody positive, this is a long dialysis vintage, this is a younger patients with the older donor. If these situations are there in high immunological risk patients, the induction therapy should be more stronger to prevent the development of the acute rejection in the transplant period. Here it is written, yes, HLA mismatches are very important, donor age is important, donor and recipient age mismatch is important, and this, apart from this is the immunology, other than this immunological risk. One thing is I want to say for the ABO incompatible, that it may be the same practice as in the non-higher risk patients, because the patient is getting at the same time a desensitizations. But second important thing is also need to be considered is the practice. That is, practice means is a high volume center and a teaching center. High volume center, if the practice a specific drug, as sir was telling, he is practicing this graphalon is a higher dosage and getting a better result. So the practice of the high volume centers, that their experience that needs to be considered. At the same time, they need to publish their experiences. And at the same time, in the teaching centers, their published data needs to be accepted. But one important thing is that in many teaching centers, the practice pattern is slightly deviated because of the treatment or the research trial. There is some PGs given this thesis is a comparison between two induction agents in different populations. So the practice pattern may not be represented by seeing the whole induction treatment in the group. Thirdly, important thing is this is the availability and the affordability. In our country like India, this is very important, because the affordability issue is there with most of the patients. One thing is important that in a patient who is a moderate or a low risk patient, the transplantation should not be denied in absence of an induction treatment. It should be very clear. But if it is the affordability is there, it should be given. And the availability is another issue, because we knew that at some point of time these are all not produced in our country. Their availability varies, fluctuates time to time. At one point of time, at 1 year time, we didn't get any ATGs, and sometime we don't get graft allowance. IL-2 blockers are recently not available. So availability is one important issue which also guides us, dictates us in terms of the transplantations. And the rest of the things, I think, is the guideline. If we produce a guideline from ourselves, from our patient, our experiences, and from the evidences, that would have been better.
Yeah, thank you, sir. Now moving on to the next part. Now we have seen the choice of induction. Now there are some situations where we are not giving the induction, but because we have to balance the many situations, like in transplant we have to balance the immunosuppression as well as infection. Similarly, we have to see the many financial factors. So I will move on to Dr. Suraj Godara for the next question. What are the factors which influence the choice of not giving induction therapy? As during the survey, there are many centers or many transplant physicians has opted for no induction therapy. So what is your choice of not giving the induction therapy?
Basically, in our center, we are not giving induction therapy in case of 6x6, that is full match, or 5x6 match with full DR match. In those cases, we are not giving induction therapy. Or in case of combined, we are also having a liver transplant program. So we are doing a combined liver kidney transplant, so we are not giving any induction therapy. Or 1 or 2 patients are undergoing patient had a liver transplant, but now they need kidney transplant. So already patients are having organ transplant on immunosuppression therapy. So we are not planning for to do the induction therapy with any agent. Those patients we are having, those are having infections with half match, 3x6 match, but having a serious infection in the past, like tuberculosis, fungal infection, or severe pneumonia. So what we are doing immunosuppression take plus minus day 5 we are starting, and we are giving only pulse, not any kind of induction. Otherwise, in all patients, irrespective of the availability, we are arranging the finance in sort of from institute or from other NGOs, and we are giving low dose like ATG around 50 to around 100 mg intravenous. Thank you.
Yeah, thank you, sir.
So next question for our panelist. So Dr. Vinand, how do you decide the induction therapy practices in ABO incompatible transplant? What is the rationale and how much dose do you use?
Yeah, so this is a very pertinent question, because when you're looking at ABO incompatible transplant patients, you're going against 2 hurdles here. So it's going to be an immunological hurdle as well as an ABO group hurdle. So the first thing that comes to our mind is that when you're going to do such kind of a transplant, you're going to obviously use an induction agent in these patients. So the induction agent which we use in our setup, and which I think has been uniformly accepted as per the guidelines and as per a lot of publications since the past 2 decades, has been a monoclonal antibody. So you have rabbit ATG, which is the most popular, and we use rabbit ATG in the dose of anything between 1.5 to 3.5 milligram per kg. And the reason that we use this is because we want to back it up with an absence of rejection, which is very important in the early period post-transplantation. And we've seen that even when you're using up to 3.5 milligrams per kg of ATG in our patients, the risk of infection somehow is not very high as has been thought of previously in other centers. But having said so, then I think we cannot generalize a dose of ATG for all the centers from our experience here, because we work in the private sector here. So I think each and every institute has to decide what is the dose of ATG that they have to give to their sensitized patients. In terms of interleukin-2 receptor blockers, we use interleukin-2 receptor blockers in patients who've had a recent history of some kind of an infection. Interleukin 2 receptor blockers not very popular in our setup. We rather would use low dose rabbit ATG as compared to IL-2 receptor blockers, because we have analyzed our data and have seen that when we are using interleukin 2 receptor blockers, we do encounter not early graft dysfunction, but graft dysfunction post 3 months of transplantation. In terms of no induction, we've never ever tried no induction in our patients who are undergoing avian compatible. We have no experience with use of alemtuzumab. And in terms of grapholon, Dr. Kher sir has very clearly pointed out that the dose of grapholon that has been used in the centers all over the country is suboptimal. And so it is very difficult to actually comment on the efficacy of this drug vis-a-vis when you compare it with rabbit ATG. But a higher dose is definitely required for grapholon when you're when you're giving it to patients who are undergoing avian compatible transplantation.
Yeah, thank you, sir. So, in continuation of this, I will move on to the Dr. Vijay Kher, sir. So, what is your comment on the not giving induction therapy in the transplant, and what is the long-term outcome of these patients we have not given any induction therapy? So, you have a lot of experience in this scenario.
Let me give you a story about no induction. In 2002, we started using IL-2 receptor antagonists, and the first patient where I used, which was in 2000, IL-2 had just come at that time in the country, and we used it, and I had a reaction in the intra-op itself. Patient developed hypotension, and so he came with an acute tubular necrosis. I had to dialyze him the post-transplant period, but he recovered, and we did not give him the second dose of IL-2 receptor because he had hypotension. I wasn't very sure whether the hypotension was related, but since this was a new drug at that point of time, then 2 years I did not use IL-2, but then there is a patient who came to me whom I had not given the option. In India, we tend to be pedagogic to our patients. We take decisions about whether the person should receive an induction or not. The discussions may not have been as good at that point of time. This patient did extremely well without induction. He was struggling with the cost of the transplant itself, so I had not discussed induction in this patient. But he came 3 months later, was doing very well. He said, "Doc, do you know about this drug called IL-2 receptor antagonist?" I said, "Yes, I know. I have used it in one patient." He said, "You didn't discuss this with me." And I said that you are doing very well, you were struggling with the cost, and he sort of, what was very right for him, said that this is a decision which he should have been taking and not I. And I think I learned a lesson there itself. Next onwards, I started discussing induction with every patient, but being guilty that many of these patients may not be able to take a decision as to what is the advantage they are going to get in terms of reduction of acute rejection. Long-term outcomes were not known at that point of time. So I wasn't very certain. So I would tell them that, okay, you have about, this is the cost of induction therapy, but you should save some 2-3 lakhs of rupees further, that if a complication arises, then you should be able to manage those kind of complications. Then guess what happened? Next 100 patients with this kind of thing, 94 patients took induction. Now the patients were making these decisions. So the point I am making is that many times physicians make these kind of decisions for patient, and I think I would suggest from my experience that all these decisions must be discussed with the patient in great detail, and you must help them to understand the data and interpret the data, because they will not be able to interpret the data. But maybe as a friend, philosopher, guide to them, give them the guidance, and then decide whether a particular patient. Most patients who are paying for transplantation will accept donation. We have made decisions about no induction many times on patients when we haven't discussed with these patients. As I said, that 94 out of these 100 patients took the decision to take induction. Now, as for your question about no induction, obviously there are still some patients who haven't been able to afford this. And we usually try, like Dr. Godara said, that try to get induction agent either through the pharmaceutical agent, because there is a 50% kind of an dosages which are provided by the pharmaceutical company, or we collect funds for many of our patients. So we are able to give induction to a good number of patients, but I think still there would be some patients who will do, and they do reasonably well. I wouldn't say that acute rejections are higher in patients who haven't received acute induction therapies, but I think on the long run, we have about 8 years of data on no induction as well. The graft and the patient survival so far hasn't been done, but we're going to publish that data, so we're looking at it more detail.
Okay. Points well taken, sir. So moving on to the next question, that is another challenging area while deciding the induction therapy, and that is the choice of induction therapy, especially in the ABO incompatible kidney transplants. So moving on to the Dr. Girish. So what is your rationale of giving induction agent, especially in the ABO incompatible scenario? How much importance will you give to the anti-A and anti-B titers at the baseline in deciding or in deciding the choice of induction therapy?
Thank you for that question. Basically, we have to understand that in an ABO incompatible kidney transplantation, the induction might start at the time when we start treating the patient, not just the one injection what we give just before the transplant. Taking that into consideration, whatever baseline is there, so that becomes maybe more important in nature to consider what is the drugs, what is the procedure that we are going to subject the patient to achieve the titers that is required in the pre-transplant period. Taking this into consideration, all the measures that is being done for the desensitization of the patient, baseline anti-A and anti-B titers assume importance. But then, if at all we look at the data, there comes like the recurrence of the anti-A, anti-B titers post-transplant, the risk of the rejection in the post-transplant period. There have been a lot of controversies regarding this. So there have been papers which say that the higher the baseline anti-A, anti-B titers, more is the risk of relapse, and the more is the risk of rejection. And there are many other papers which refute this also and give more importance to the pre-transplant anti-A and anti-B titers. So ultimately, it is not very clear that which is the titers that is more important, which determines the long-term outcome. Because most important in anti-A, anti-B, that is ABO incompatible transplants, is the accommodation that happens in the immediate post-transplant period, that is usually the first 2 weeks post-transplant. And hence, a very clear-cut answer for that question is not possible. But however, since the baseline titers are more important in deciding what is the procedure that the patient has to undergo, I would say that a baseline anti-A, anti-B titers would be more important.
Then now moving on to Dr. Swarnlata, we can see the response rate. Around 9% of the respondents have said they use 100 milligram of rituximab in ABO incompatible transplant. 48% centers say they use 200, 17% are using 500. So there is a lot discrepancy. What is your opinion regarding dose of rituximab in ABO incompatible transplant?
So first of all, I would like to congratulate the organizers for having brought this into the panel discussion, because I think it's a need of the hour with changing the practice patterns and evolving literature. As has been mentioned by sir, that 2009 guidelines says still that you have to use bacillus for even the low risk immunological risk in patients. But however, now even with the evolution of the literature, even now if you look at the European population, still use bacillus as majority of the patients. But if you see US, they have shifted to ATG. But our India, I think we have come up with a very nice data showing what is the practice pattern in India, and I think it's still heterogeneous.
Yeah.
And coming to our experience, with the 2 decades of experience when I was resident, we used to use a lot of bacilliximab, particularly in the patients, even including high-risk patients, and no induction with low-risk patients. But our program has evolved, and we do a lot of now deceased donor transplantation. So we have shifted our gaze to more of ATG in high risk and bacilliximab in low risk. And of course, we have reduced the number of patients who have no induction. So, but still we have 10 to 15% of the patients with no induction. So that's been has been our practice pattern. And again, we try to, we have also availability of this, the investigations to how to assess this, stratify the immunological risk basing on what we have, this, the flow cytometries, and then, the solid phase assays, and then high resolution HLA. So I think these has to be utilized to, the assessment of the immunological risk and optimization of your induction therapy. Now coming to the, the rituximab in ABO incompatible, your question, I think I am not be the right person because I don't have much experience. With whatever little experience, what I can say is, of course, it is also evolving. Initially, they used to use high doses of 375 milligram per meter square body surface areas. 2 to 4 doses before transplantation, 2 to 4 weeks before. But now with the experience again, patient have realized that there is more of complications, infectious complications, and they have reduced the dose to around as less as 100 milligrams also. So, our experience, we have used 200 milligrams 2 weeks before, and we could have a better outcome. So, I think it all experience, and the other has been discussed by the previous panelists. All the other factors also determine what is the titers ABO, antibody titers, and what are the patient factors. All these should be taken into account before you calculate the dose of this rituximab in ABO incompatible transplantation.
Yes, sir. I was going to come to you, sir, only. So,
yeah, see, people started with 500 milligrams of rituximab.
Yeah.
This is from the Japan, basically, where initially splenectomy was being done. And it was realized actually that 100 milligrams, 200 milligrams, and 500 milligrams probably produce the same effect. These CD20 count, which is, or CD19 counts, which get reduced with rituximab, obviously go down. And 100 milligram produces a reasonably good reduction before accommodation occurs. So 100 milligram. But there are programs in the world which do not use rituximab and are still successful. And in fact, there is a trial with Dr. Montgomery and Doris Sagiv did. They used rituximab and didn't use rituximab in about 32 patients in each group, and found that the outcomes were very, very similar. So there are centers in ABO incompatible transplant still remains an art. The science of ABO incompatible transplant, as far as I know, is still poorly understood. What is the antibody titer which is important, I don't know, because there are some centers in Japan which don't look at antibody titers at all. They do 3 plasmapheresis before, 1 plasmapheresis later, and don't look at the antibodies at all. But there are other centers which go down now. Acceptable titers at the time of transplantation is 1:64 or 1:32 in vast majority of Japanese and other centers across the world. And there are centers which have looked at 128 as an acceptable titer for transplantation. So I think, I don't know what titers mean at the moment. Probably what matters is the level, probably ABO antibody at the endothelial level, which probably is important for causing acute rejections, especially that acute rejection, antibody-mediated rejection, which is like an antibody-mediated rejection in an ABO incompatible transplant, which is probably an endothelial process which occurs in these patients. Occurs fortunately in less than 2% of patients, but if it occurs, then it's very difficult to save this graft.
does, sir, pre-transplant baseline titers before induction, if those are high, 1:1024, 2048, does that affect deciding the dose of rituximab?
I don't think titers make much of a difference. There is a paper in, I think, Journal of Nephrology from Japan, and they looked at looking at CD19 count, and if a dose did not reduce CD19 count to less than 1%, they would give another dose of rituximab of 100 milligrams, and then showed that if they haven't used CD19 count in people where there was no reduction CD19, their rejection rates were higher in that group of patients.
So how many days after rituximab should we look at CD19?
5 days. 5 days. 5 days later.
So if we start at -14, after say -9,
later, and then this is one paper which has come. We haven't yet followed it in our own.
Okay.
We give about 200 milligrams, and we have seen
Fine.
severe reductions in CD19 counts.
Thank you. Thank you.
If I may add just one more note, I was just discussing this morning with Dr. Suraj, who has done a lot of ABO incompatible transplant, and even the other data that shows the higher titers, in the initial baseline titers, if it is more, maybe the person will require more number of plasmapheresis rather than higher dose of rituximab.
Right.
So this is what
Yeah,
most of the
obviously,
data shows.
higher, higher titers, if you do plasmapheresis in them, then you will require larger numbers. We did one patient with 4,028 and two patients with 2,048. But in these patients, we used the filters rather than plasmapheresis because it's not feasible to do such large number of plasma sessions that they need in these high titers.
Yeah, thank you, sir. Now we learn that over a period of time we are becoming more and more bold. We are reducing the dose of immunosuppression to improve the outcome and to prevent the infections. So moving on to the next topic, that is the induction therapy practices in the high immunological risk recipient. So I will ask the Dr. Vivek Kute about your experience and the comment in terms of the considering the high immunological risk patients, how you are choosing these induction agents.
Yeah, the survey response is quite clear. Like 88% of the participants mentioned that they will use thymoglobulin in high immunologic risk recipient. So that is common practice in India, and most common is what is a dose. For example, in our center yearly we do around 400 kidney transplant. 50% are deceased donor and 50% are living donor. And in living donor, spousal donor are very common. So in case of deceased donor transplant and spousal donor, we use 3 mg per kg of thymoglobulin. And when we decide the dose of thymoglobulin, it is very important what dose of maintenance immunosuppression we use. It is better to use a higher dose of thymoglobulin with a lower dose of prednisolone and CNI levels. Of course, we can give 2 mg per kg of thymoglobulin for deceased donor transplant, for spousal transplant, but it depends what is your maintenance immunosuppression. But now the steroid, tacrolimus and mycophenolate is fairly standard triple drug immunosuppressive regimen. So in this case, it is better to use the higher dose of induction therapy. And coming to the published evidence, what is the definition of high immunologic risk is very important. It should be defined by retransplant, higher level of DSA and PRA. When we see the KDIGO guideline and Cochrane review, the KDIGO guideline is of 2009, where majority of the data included in the analysis, like more than 80% was cyclosporine base, and azathioprine was also very common at that time. So deciding for deciding the dose of thymoglobulin, we must consider the dose and level of maintenance immunosuppressive regimen. So for India, majority will agree that for high risk patient like deceased donor and spousal, thymoglobulin, and for the parents as a donor, IL-2 receptor blocker. And when we decide about the induction therapy and dose in Indian scenario, it is very important to mention that death with functioning graft because of infections are very common in Indian scenario as compared to the Western practice. So we must take this into consideration about the infectious side effect when we decide the induction therapy.
I would like to make a point that whatever we are discussing here is in the tacrolimus era. So earlier studies, publications were for when the cyclosporine was commonly used. So the long-term data regarding induction, when instead of cyclosporine, most of the centers are using tacrolimus. So we are trying to assess that. So Dr. Pratik, what do you think, what is your practice when it comes to use induction therapy for low immunological risk recipients? We can see the response that nearly we have got the response of around 28-30% for no induction preferred as versus IL-2 blockers and rapid ATG.
In contrast to the patients who are at high immunological risk, whereas there is almost unanimity of using these depleting agents and the induction agents, but in the lower risk group, you can see is in our survey also, it is showing it is not uniform. The two questions are there. One is whether to give no induction versus induction treatment in a patient who is at low risk group. Whatever data we have available, specifically the Cochrane, the second and the third analysis, 2017 and I think 2004, and involving almost 2,000 and 5,000 patients involving no induction versus first one 5,000 data is in comparison to the no induction versus IL-2 blocker, and second one was the no induction versus ATG, in which have shown that immediate short-term as well as the long-term outcome is better if we use a patient's an induction agent compared with a no induction agent. So whenever we are using using this induction agents, first one we have to need to be very clear whether the patient is at low risk or not. Secondly, if there is an affordability, yes, induction treatment should be given, and that can be as per practice. It can be an IL-2 blocker, either or, because that data showed that there is hardly any difference between the two agents in the low induction group, but they are better in short and long term outcome in relation to the no induction group. But one important concept has emerged which are probably not there is called cumulative immunosuppression. Suppose if we are not very sure the patient is of high risk, because we are detecting only the HLA mismatches, we are seeing these anti-HLA antibodies and not seeing the non-HLA antibodies and so many other immunological factors. See if the patient is not like that, and there is always possibility of developing a rejection post-transplant period, and that requires a lots of immunosuppression. So if we are started with a low or no induction treatment, the cumulative immunosuppression becomes high. And secondly, second important point you need to think of, as we are seeing all the patients in a long-term basis after the development of both these induction agents, maybe 5 years, 10 years, 15 years, now we know that most important threat to us is the development of the de novo antibodies as well as development of the chronic antibody-mediated rejection. We need to think both of these also. Getting an immediate post-transplant success is not enough. Getting a 5-year survival is also probably not enough. We need to reduce the production of these de novo antibodies as well as production of the development of the chronic antibody-mediated rejection. So in those situations, I think considering all this, in our practice also in our hospital, we also practice an induction policy for all patients who can afford. And we usually use ATG at a lower dosage. This is a 2 milligram per kg body weight for this patient compared to our standard practice of 3 milligram per kg. And we maintain them with a standard triple immunosuppression like that of a tacrolimus, mycophenolate, and these things. And I want to last mention this: in the recently published German data of 615 patients with a low risk group comparing this ATG with glucocorticoids compared to IL-2 blockers with glucocorticoids, with IL-2 blockers without glucocorticoids. They have shown there is hardly any difference in the low risk group in the immediate post-transplant as well as at the end of 1 year survival.
Yeah, thank you, sir. So moving on to the...
Just one thing I have already told, that no patient transplantation, even in the low risk, should be denied in absence of this induction treatment.
Yeah.
Thank you.
Moving on to the induction practices in the living donor organ recipients. Now there are some situations like adolescent recipient and the elderly donor. In such scenario, the next question is for the Dr. Suraj Godara. Elderlies are more prone to infections, and adolescents have the more and more T cell repertoire. They are more prone to rejection. So does age matter in deciding the induction agent, and how much dose would you recommend in as per these ages?
In our center, we consider high risk young recipient, elderly donor, disease donor. Second transplant, if first transplant failed due to any chronic type of rejection, and husband to wife transplant, transplants which are having flow is positive, but we are doing single antigen. Single antigen is showing non-DSA, but there is still non-DSA antibodies. So we are giving ATG in all these patients around 3 mg per kg. In case of like husband to wife, we are giving more dose because husband kidney is difficult to tackle by wife. So we are using around 3 to 4 mg per kg, depends on the age. If more than 50-year age, then we are giving 3 mg per kg, and if less than 50, we are giving 4 mg per kg. In the elderly patients, like sir had said, if they are having more than 60 years of age, having history of infection, we are giving IL-2 induction therapy.
As we are running short of time, I will request our panelists to give a short narration of the scenarios. So, Dr. Vinant, what is your practice when it comes to use of induction in adults with low immunological risk?
So as we all
And
know
what
that
is the dose? Yeah, dose also, sir.
Yes, in terms of doses, I think the survey is very much representative of people following the KDIGO guidelines, but I'm not really sure if, because this is a practice pattern evaluation, that's what we're discussing. What we've noticed is that most of the people who get referred to us also after a transplant, what we notice is even patients who are in low immunological risk, low dose rapid ATG is very, very popular as compared to IL-2 receptor blocker, primarily because of two reasons in this country. One is the cost issue with the IL-2 receptor blocker, if it does have to be used in low immunological risk. And second is the availability of IL-2 receptor blockers. There has been problems in the past few months in which the availability of this drug has gone down because of market forces. So people are using more of low dose rapid ATG. In terms of no induction, that is, no induction is more popular in patients who come to our center from government hospitals, where obviously the first thrust is on saving the money of the patient. And when you're looking at the data and you analyze literature in the past 3 decades or so, the data also shows very clearly that low dose ATG can be used in patients with low immunological risk, and there is lesser chances of infection, lesser chances of rejection as compared to IL-2 receptor blocker. So the doses that we use for rapid ATG in low dose is anything between 1 to 1.5 milligram per kg. And interleukin-2 receptor blocker has a very standard protocol which is followed by all centers uniformly.
Thank you, sir. Moving on to the elderly recipient. So I will be very crisp and to the point that for the elderly recipient, that question is for the Dr. Girish. What is your dose and the choice of induction agent in the elderly recipient?
Well, even here the graph is pretty representative of the practice pattern. When it comes to elderly recipients, we are always afraid, not just elderly, whatever the patient might be, we always have to balance the risk versus benefit. And we know that the elderly recipients are little less immunological risk and they are more high risk for infection. So I would like to keep the immunosuppression slightly lower as compared to the regular adult patients. So my personal preference is usually interleukin-2 receptor blocker. But here in the graph, we can see that most of the people have gone for rabbit ATG, which is slightly higher than. So, but as Dr. Vinant pointed out, it might be a low dose what they might be offering them. And analyzing the graph again, there is another group here that is same as in adults, which comes to 20.5. And if at all, even if they are referring the 2 as the interleukin-2 receptor blocker, that might get split anywhere between interleukin-2 receptor blocker as well as rabbit ATG. So we don't know whether it will be the interleukin-2 receptor blocker or the low dose rabbit ATG, which would fare well in the ultimate response according to the practice patterns. My personal preference would be to keep the induction therapy to the minimum in elderly patients. So either no induction in those who can't afford or an interleukin-2 receptor blocker. And of course, as Dr. Vinant pointed out, sometimes they want an induction, but they can't afford an interleukin-2 receptor blocker. So a low dose rapid ATG also can't be ruled out.
So, Dr. Swarnlata, in case of adolescents who have a good T cell repertoire, so what is the dose and type of induction which you prefer? And do you give it in a single dose or divided doses and looking at the lymphocyte count?
No, as has been discussing for the past few minutes, the younger age falls under the category of high risk. So definitely we would recommend the induction therapy. So my choice would be ATG, and we give in a divided doses to 1 to 3 milligram per kg body weight. But having said this, We do have a category of patients like recently we have transplanted 11-year-old child with ejection fraction of 25. He always come up with pulmonary edema and then the lower respiratory infection. So we had transplanted and the donor was father with haplomatch, and then we have given no induction therapy. So it all depends upon the other factors also. So but by and large, younger patient, particularly female with the pregnancies and then other risk factors of high falling under the high biological risk, I would always go for the ATG as induction therapy.
Thank you, madam. Pertaining to the same topic, that from adolescent to the coming to the pediatric recipients, Dr. Vivek Kute, what is your choice of induction agent and dose in this?
So in pediatric, majority of the donors are usually parents donor. If parents are donor, we can go as per the KDIGO guideline. But many centers also have the option of thymoglobulin in view of young age as a high immunologic risk as per the KDIGO guideline. So practice pattern differ, but we can go as per the donor selection and what maintenance regimen we want to give in this pediatric population.
So this question is for Dr. Pratik Das and Kher sir, that whether the presence of diabetes decides the dose of induction and the type of induction in your practice from living donors.
So whenever we are doing transplant in a diabetic recipient, the 2-3 issues are important. One is chances of infection may be slightly higher, specifically to the pyogenic organism in the immediate post-transplant period. Secondly, very difficult to control diabetes in the immediate post-transplant period when your patients are getting tacrolimus and high-dose steroids. And thirdly, the associated comorbidities in terms of cardiovascular or cerebrovascular abnormalities. So in these situations, the immediate post-transplant period is important. In those situations, we might need to reduce the steroid dose very fast, or we may have to withdraw the glucocorticoid for the proper glycemic control. We may have to reduce this tacrolimus dosage, or sometimes even extreme situation we may need to change it from tacrolimus to cyclosporine, like that. So the maintenance immunosuppression is slightly maybe different in the diabetic recipients, and associated the atherosclerotic process also may be very much progressed by using these high-dose steroids. So keeping in this mind, as there is some amount of uncertainty or some amount of the variation in the post-transplant maintenance immunosuppressions, it is, in my opinion, or in our practice also, it is always better to, as the survey is clearly showing, it is better to give the proper and optimum dose or the most effective dose of this induction treatment by using this ATG. And also, probably if the patient is already in the infected state, may have a tuberculosis history or maybe have more infective immunology. In those situations, IL-2 blocker can be chosen. But in our practice, we give ATGs most of the patient until unless they have an infection in the immediate pre-transplant period, because we may need to reduce the steroid and tacrolimus dose a bit differently than the other patients.
So now we circulated the survey and we analyzed the practice pattern and disease donor also. As we are running short of time, I will just show the results and we'll have some closing remarks from our panelist. So the survey in case of what is the preferred induction for a standard criteria disease donor when the patient is receiving kidney transplant. So 80% said they prefer the rabbit ATG. 6% went for around 6.3, 6.3 for IL-2 and graphelon. And when we asked what is the preferred induction in case of expanded criteria disease donor, again the result was favoring the rabbit ATG, around 77% opted for rabbit ATG. Then we saw the response when the disease donor is having acute kidney injury. Most of the centers are using rapid ATG, around 72% centers opted for that. And again, if the recipient is receiving the kidney from the diseased donor with active potential infections, so what is the preferred? Here there was some change in the pattern. So around 29 to 30% centers preferred the IL-2 blockers and 33% preferred rapid ATG. So I would like to have the final comments from Dr. Kher. what is the dose of ATG in case of recipients who are receiving kidneys from the deceased donor with potential infections and active infections?
Actually, I feel that the fear of infections in transplant recipients is predominantly related to the malnutrition which is existing in our chronic CKD patients. And I think majority of our CKD patients, and I can tell you this from experience, that when I moved from Lucknow to a private institution in Delhi, the kind of patients that you see is different. Obviously, the government setup, you have people who are not that well-to-do, and therefore their nutrition is poor. And I think the infections are predominantly related to that. They're malnourished as well. And I think nutrition is not being given the same kind of attention by nephrologists. And I feel that that's something we should try to improve in our patients prior to transplantation, both in dialysis as well as in non-dialysis population. This is neglected, and I feel that that's an important risk factor for post-transplant infections as well, because the general level of well-being and nutritional health is poor in our transplant recipients, and that is what predisposes our patients. Induction is predominantly given for the immunological risk that is there, and I think one should assess immunological risk by as much immunological evaluation as is possible. Fortunately, I feel that high resolution DSA is available and high resolution HLA typing should be done in all patients currently. I do not want anybody to do a low resolution HLA typing because the cost is exactly the same at the moment, whatever is available wherever in the lab. So I think high resolution HLA typing should be done. You will get better evaluation of the risk factors as well, immunological evaluation, and then that will determine. If your patient is at a relatively high risk, even if there is a potential for maybe the dosage of the thymoglobulin could be reduced, as Vinanta said, people have used 1 to 1.5. There is literature suggesting that 1 to 2 milligrams may be okay in this group of patients, which is probably providing a kind of immunosuppression equivalent to IL-2 receptor, because there are comparative studies on that. 1 milligram to 2 milligrams of thymoglobulin versus IL-2 in some of the studies. I excluded them from my presentation because of the time constraints, but there is enough data on that those patients probably 1 to 2 milligram may be okay to use. But as I said, I think in the general population of transplantation where you have to use thymoglobulin, 3 milligrams seems to be a sweet spot of providing a good immunological coverage for reducing acute rejection as well as preventing high risk of infections in our patients. And I would say that although
I'm really sorry for the interruption,
many patients are saying that probably 50% of, say, HLA 3/6 mismatch, which is parents, brothers, sisters, or sometimes other cousins and all. So you would require, as has been shown, that thymoglobulin provides immunological reduction of acute rejections. IL-2 doesn't provide that kind of, in a fairly large number of patients in our study.
Yeah, thank you, sir. Thank you, all the panelists. So I am declaring that the panel discussion is now over, and I request all the delegates to join for the lunch. Lunch will be provided on the first floor. Thank you.